Hi, my name is Nicole.
My name is Mindy.
My name is Lila.
My name is Amy.
And my name is Kimberly.
According to Williams, Hubbard, Day, and Barden, 2012, in Critical Care Nurse, telecommunication technology is utilized to provide evidence-based and innovative care. On behalf of DRHA, our team was formed to address the ongoing issues of informatics-based clinical issues. We have been presented with a scenario in which Mr. Kenneth Lister was admitted to the ICU with hyperglycemia and arrhythmias after he was found in his home lethargic and unable to communicate. The ICU nurses have initiated the intensive insulin therapy clinical decision support system to control his hyperglycemic episode with a plan to transfer him to a medical step-down unit once stabilized. The IIT CDSS is a new protocol to the ICU, and the medical step-down unit does not yet use it. We will discuss the importance of communication between the ICU and medical unit in question, which includes technological aids and communication regarding protocols such as the IIT CDSS initiated in the ICU to improve patient outcomes, such as Mr. Lister's case. Lila, how will you, as the ICU nurse, integrate the IIT CDSS into your practice and effectively communicate with the nurse on the medical unit so that she or he can continue blood glucose control in preparation for discharge?
As the ICU nurse integrating the technology into nursing practice, I would have to consider the nature of nurse involvement with the development and implementation of technological interventions. One study performed by Drs. Moore and Fisher in 2012 and published in the Computer Informatics Nursing Journal interviewed nurses of varied experience, some without, actually all without any formal informatics education. What the study demonstrated was a general uneasiness amongst experienced nurses with technology driving a discomfort related to the transparency and sense of constant monitoring, feeling that impedes the ability to manage and effectively prioritize their patients' care. Interestingly, novice nurses in the study seemed to express a higher level of comfort, even curiosity related to the improvement and increasing functional use of systems in application of technology in their practice. The implementation of the IIT, or the intensive insulin therapy in particular, as an ICU nurse, involves primarily following facility protocol as it relates to the IIT, while implementing physician's orders, notifying physicians regarding concerns with any recommendations by the CDSS, and then documenting all activity related to the patient care, communicating all interventions, and documenting that communication. There has been some controversy amongst studies regarding the appropriate use of IIT in critically ill patients, and I think that needs to be taken into consideration. One international study of over 6,000 patients regarding the appropriate use of IIT in critically ill patients was published, let's see, in the New England Journal of Medicine in 2009 by a group known as the NICE Sugar Study Investigators, and it's well over 300 different physicians that participate in this group. And what they found was very, very strong statistical evidence with a p-value of less than 0.001 that intensive glucose control actually increased mortality amongst adults in the ICU when attempting to control blood glucose between 81 and 108. ICU experience generally teaches the vital importance of utilizing tools to assist in evaluation of a clinical situation, but importantly in balancing the technology with the education and experience so that the nurse will know when a recommendation made by a system may not be appropriate for the patient as far as an intervention. Understanding that balance and participating in the process to improve these systems allows for greater applicability in nursing practice. The combination of nurses' skills, clinical skills, and data processing mixed with knowledge and application of theory is documented notably to result in better decisions than would be made by either alone. And there is a study that was printed in, let's see, again in the Computers Informatics Nursing Journal in 2010 by Drs. Cho and Staggers that references specifically the nature of the importance of mixing clinical skills and technology. Communication specifically regarding this instance to the medical unit, because they don't utilize the IIT, would involve effectively providing that information with regard to the blood glucose data to the medical nurse in order to ease a transition to a more conventional means of blood glucose control in order to prepare the patient to go home on a far less intensive means of blood glucose control. Shirley Moore participated in a project called the European Handover Project that was published in the Quality and Safety Journal in 2012, and the things that she focused primarily on in her study with transition of patient care between settings are that report should be a combination of both written and oral information. It should always allow for opportunity to ask questions. There should be a facility protocol in place when formulating the content so that all necessary information is included, and that inclusion of patient and family goals is vital to facilitating the best possible outcome for patient transition. Method of blood glucose control in a medical unit is going to be determined by hospital protocol and hospitalist preferences. So beyond providing that data from the CDSS and the recommendations that had been made to the physician regarding the nature and success of blood glucose management in an intensive therapy, the remainder would just allow for transition orders to a more conventional approach appropriate for use in the medical unit setting, excuse me. Communication of this rationale to the medical unit receiving nurse, along with thorough verbal and written report, question sessions, of course, and then inclusion of treatment goals, should allow for a successful handoff of the patient for continued blood glucose management and preparation for discharge.
Thank you for that, Lila. So Mindy, would you be able to explain to us why a nurse chose to override the CDSS and how this could be prevented?
Absolutely. So Campion in 2011 in, let's see here, the Journal of American Medical Informatics said basically that the standard of critical care was the intensive insulin therapy, but that recent studies were questioning the treatment's mortalities and benefits of the patient's safety, basically. And that was really because of the overrides that the nurses were doing with the CDSS. And further research was suggesting that nurses were overriding because they were pretty much afraid of causing hypoglycemia in the patient. And so this study actually stated that overwhelmingly the nurses administered less than recommended doses, which emphasized prevention of hypoglycemia but interfered with the hyperglycemic control. It was also suggested that this can be happening because of a couple things. One being really lack of education, and that in order to prevent that, we're going to need to really educate our nurses better so that they really understand why we're using the CDSS and why overrides aren't really a good idea and not necessary for really facilitating the best patient care outcome. Along those same lines, Cho and Staggers and Park in 2010 in Computers Informatics and Nursing Journal, they specifically talked about that lack of education and that the CDSS also takes more time to follow. And so sometimes people feel that taking shortcuts can just really allow them to move on with the process and take care of their patient faster, even though the standard of care with the insulin therapy and more CDSS support systems that are in place would allow for a better quality patient as well. Another study completed by Dowding in 2009, and that was in the Journal of Clinical Nursing, suggests that overrides in CDSS occur as a result of an interaction between a nurse's experience and their ability to adapt to the technology and fit it with their local clinical practices. So the world of healthcare we know is changing, and clinical informatics is definitely on the rise, so nurses just need the necessary training to increase their comfort level with all technologies and really understand how to fit that into their clinical practice. And that will really be the only way that we're going to prevent that is through education as nurses.
Great input. Thanks, Mindy. Amy, what about PDAs? Do you think using one in the hospital would have helped with communication between nurses?
Certainly, and I believe this patient case provides a great example of how personal digital assistance can assist and enhance nurse-to-nurse communication. For example, handoff, review CSS, review history of blood glucose, insulin use, and the effects which reinforces with CSS with the patient gathering. A little background, transitions of care include great opportunities to ensure that a couple of safeguards are in place for safety and quality. One being medication reconciliation. Total Youth Board's Young 2012 article published in the Journal of Medical Systems indicates that medication errors account for an estimated 40% of adverse events in the hospital system setting, with most errors occurring during transition of care. Medication reconciliation identifies and reduces errors as much as 76% according to one study. Another area is clinical handoff communications. Hunt and Staggers 2011 article posted in the AMIA Annual Symposium Proceedings Archive indicated that improving clinical handoff was actually Joint Commission National Safety Patient Goal initiated in 2006. Indicates that ineffective handoffs have been associated with adverse clinical events. What they found was that computerized clinical handoffs can streamline much of the perfunctory preparation work, provides easy clinical information, and can ease the mental burden of staying up to date with all of the clinical activities, which ultimately may reduce inadvertent clinical mistakes. So looking at PDAs specifically to foster this clinical handoff and medication reconciliation. So they're mobile, user-friendly devices that can assist in facilitating clinical handoff and medication reconciliation during transition of care. And that was pretty much the consensus of Port U. Ward, Swain, and Young, 2012 Journal of Medical Systems, and Hunt and Staggers, 2011, the AMIA Annual Symposium Proceedings Archive. So some of the benefits would be beyond the clinical handoff and medication reconciliation. You would have instant access to patient EHR and all the associated tools. Bedside PDA use assists in maintaining patient safety and efficiency of care through numerous available functions and applications that foster nurse-to-nurse communication. For example, CDSS software, easy retrieval of evidence-based practice and pharmacological information, as well as time management and scheduling tools. When looking at Snyder et al.'s 2011 article in the Cancer Journal talking about and discussing patient-centered care, Here's an opportunity to provide high-quality patient educational materials and tools. They're easy to carry, they're easy to use. That's in, according to Hudson Bell 2011, Journal of Nursing Management. They additionally sync with the main database, eliminating duplication of entry. That's according again to Hunt and Staggers. So some potential barriers. The cost of the device and software applications. That is according to Hudson and Bell, 2011 Journal of Nursing Management, did a study on nursing students who were required to purchase this technology as part of their program. And those who did not use it posed that as an issue. Additionally, poorly designed software can lead to underuse of the system and development of workarounds, resulting in subpart handoffs, medication reconciliation, and an EHR that is not updated, as well as it can lead to alert fatigue as identified by Hunt and Staggers. Sidebottom, Collins, Whitson, Knutson, and Britt in 2012, CIN Computers Informatics Nursing. Additionally, as with all workflow changes, clinician buy-in can be difficult, and training is an investment and a necessary entity when you're introducing new technology and workflows.
Thank you. That's all great information. So, and finally, Kim, are there any other technological devices that may help with transfer of patients between ED, ICU, medical unit, and discharge to home?
Well, in April 2011, the California Healthcare Foundation issued a brief with case summary interviews for using tracking tools to improve patient flow in hospitals, with an emphasis on throughput. Throughput is the ability to efficiently move patients through the treatment process. New patient tracking systems, such as real-time locator systems, RTLS, aid in that throughput process. Evidence of real-time tracking systems are that they increase throughput, there are fewer diversions, and they increase patient satisfaction scores. Real-time locator systems can use software that pulls data from clinical information sources such as gender and status. These systems can also use advanced technology such as infrared and ultrasound. Real-time locators can also track staff and equipment so less time is wasted looking for things. RTLS systems in the ED is updated in real time, so when a patient is moved, real-time tracking is given to the doctors, nurses, and technical staff. RTLS systems can link patient tracking to discharge planning to indicate time remaining before a scheduled discharge and a notification to alert staff. As a DRHA committee member, you must consider advantages and possible disadvantages to RTLS systems. As illustrated on documentation provided by Barry Runyon in Hype Cycle for Healthcare Provider Technologies and Standards in 2009, it was indicated that RTLS systems may include required devices such as receivers and network devices. Infrared requires transmitters in each room where coverage is needed with a costly intervention. Questions the DRHA should ask themselves is, do we need a tracking system to improve patient flow? Do we need real-time data, or will our existing sources suffice? Will staff accept this new system, and will it influence their workflow without causing alert fatigue, which was highlighted in the readings from Computer Informatics and Nursing in 2010, Reactions of Nurses to the Use of Electronic Health Record Alert Features in an Inpatient Setting? And lastly, will this facilitate or distract from patient-centered care, such as it concluded in the Cancer Journal in 2011 in the role of informatics in promoting patient-centered care? Thank you.
Thanks, Kim. Real-time locators sound really interesting. So, in conclusion, we found that although information technology in patient care can potentially serve as a barrier to patient-centered care, such as dehumanization, increase in bureaucracy, and interfere with doctor/nurse patient relationships, and that's according to Snyder et al. 2011 in the Cancer Journal. The advantages of using information technology in patient care settings greatly outweigh the barriers. As Lila identified, handoff communication is most successful if given through verbal and written reports to include time for questions and discussion of goals. Information technology can enhance the handoff communication between caregivers on different units, as it easily helps to coordinate care and share information with other clinicians. And that's according to Snyder et al. In 2011 Cancer Journal. Many discussed that the nurses may be reluctant to use clinical informatics to initiate protocols. However, proper training and exposure increase comfort levels and emphasize the importance of using clinical informatics to deliver quality care. The use of PDAs can alleviate the burden on clinicians of time constraints, as they are easy access bedside use devices that can help maintain patient safety and efficiency, as Amy acknowledged. If PDAs are unavailable to clinicians to aid in the care of patients, other technological devices are available to aid in communication, such as real-time locator systems, according to Kim. So based on our findings through evidence, we recommend that the use of technology be utilized to enhance communication amongst healthcare providers in the transfer process of patients between clinical units. However, information technology should not solely be depended on to provide optimal care, as it should not replace person-to-person communication. Our plan recommends to continue the use of clinical informatics protocols such as the IIT CDSS, as well as provide ongoing training and support for nurses on the use of health information technology to enhance communication. Thank you for taking the time to listen to our discussion and recommendations. This concludes our discussion.